everybody. Welcome to Ask the Anabolic Doc, starring Dr. Thomas O'Connor, brought to you by his websites, metabolicdoc.com and anabolicdoc.com, both of which you can get this book, America on Steroids, A Time to Heal, also available on that crazy Amazon.com website we all love so much. Dr. O'Connor, how are you, sir?
What's going on, Ron? How you doing, my man?
I want to start this episode by berating our viewers, you terrible viewers. Why? Because the last video we did was called The Risks of Using Steroids, which, it's very important because there's a lot of guys out there watching these videos that do use steroids or they're going to use steroids, and you'd think they'd want to know, geez, what can these do to my heart, my liver, my kidneys, you'd think that would be a concern, but the views just weren't there. But
Wow.
then, we do a video about tren and it gets, all kinds of views. Your video on tren, I think it's in the very, very high six figures. It's way up there now. Tren.
But I learned that a couple of years ago when I was standing in front of my whiteboard talking about the heart and all this. I get some traction on that nowadays, but I was amazed. And then I just did something about Rich Piana's death or Dallas McCarver, tren, Diana Ball. Those are my biggest videos.
Yeah, well, I pay a little more attention to what videos people are watching. And if you do a video on how to use steroids, or particularly if you're giving away the secrets of the pros and their steroid cycles, oh my God, you're going to get views like you could not believe. Because everybody wants that magic bullet. Okay, so you just did a video a couple weeks back. I believe it was called Low T Signs and Symptoms, something like that. Anyway, guys, it's on his channel, Anabolic Doc, on YouTube. It's got timestamps. It's very well referenced, very professional. This is not going to be that. I want to approach this as if, I'm a guy walking into your office. I've booked my appointment. I won the lottery and I got an appointment with Dr. O'Connor. I'm probably like a 40-year-old CEO. I don't know. I'm a very successful man. I'm in the Northeast of the United States somewhere. And, I want to ask you about TRT, if maybe I need TRT. So how do you evaluate somebody? What needs? I mean, I'm sure there's a whole slew of things based on labs, based on testing, but what are the first things that you look at with someone when they come into your office thinking that they have low T?
So that's a great question. And that's like, so all over the world. What is it? It's really clinical symptoms, so it's a man who doesn't feel well. Of course, then there's the clinical side. Then you have to support it with those numbers. And then you have to put those together for a diagnosis and try to find, can you reverse any of that? Yeah. Can you find a reason why he doesn't need, this is how my approach is, before you, these are not steroid users, right? These are not. Well,
I mean, let's lump everyone into one category. So if someone walks in, they hand you over their last blood work and I don't know, let's say their testosterone, what levels, I'm sure this is just the beginning of the process for you, but what numbers are you looking at and what ranges do you first look at to even see if they're in the ballpark for being considered for TRT?
So there's some argument on this, but everyone's going to agree that you take a man into your office, if you're an endocrinologist or a testosteronologist like me, a urologist, or some, hopefully a real medical doctor that has some experience and credentials to make these decisions, apart from the anti-aging places, which I just can't respect. Those are not even doctors now. They're hormone specialists. Maybe it's a nurse or something. That's not an expert that's, in my opinion, should be having that authority to do that, because you can destroy someone's life. So a man comes in, you sit him down and hi, sir, how are you doing? So what's going on, sir? How can I help you? What's wrong? Yeah. That's number one. And that's what doctors, unfortunately, don't really do that. They just go right to the number. So the first thing is, how are you doing, sir? What's your history? Why are you here? I mean, I do Zoom and Skype and FaceTime all over the world, Africa today, South Africa, UK today, America. So I mean, what can I do for you, sir? And then the man goes right into exactly why he's not there. He could be somewhere else who wants to hang out with a doctor. So he comes in because he doesn't, why, doc? Well, okay, in my office, it's probably a man who's used testosterone or steroids already, probably not a professional, just a regular guy. And now he's either on it and he's concerned because he can't get off, or he feels bad, or he is off and he feels really bad. He's or relatively bad, that his sex drive is down, its energy is down. He feels malaise and fatigue.
Yeah.
And then of course there's guys that come in because they've already had a severe or some medical complication related to androgens. So men come in, if the average bear comes in, there's two average bears, one that's never used steroids and one that's been exposed to steroids. Let's talk about the one guy who's an executive. Don't say the executive that doesn't use steroids. The executive guy, they love steroids too.
Who doesn't love steroids? They're awesome.
Men love steroids because it makes them bigger, faster, stronger. It makes them hornier. And when they go to boardrooms, I have some of the wealthiest, successful men in the world. Doc, ask me why I take testosterone. Why do you take testosterone, sir? Make more money and have great sex.
Yeah.
Oh, okay. Well, that's great. So this is what this does to you, sir? I thought, to myself 15 years ago, yes, doctor, this is what this does for me. But I'm losing my hair, I'm puffy, I've gynecomastia, I had my heart, I'm concerned, my hypertension, my prostate. So I have overnight, I guess, or over 10 years, I have a full day job. So the guy doesn't feel good. He's low testosterone. Maybe he's really low, like he's older now and he has years of diabetes or sleep apnea and he's heavy. And then his testosterone is less than 300 or 250. And that's on a total scale of nanograms per deciliter.
Yeah.
Or picograms per milliliter, which is a different scale. And again, it's just about the numbers on paper. And if the guy has really low testosterone and you repeat the test multiple times, as per some of the experts in the world, and I'm not belittling them. That's how you should do it. You should consider doing it. Do you need a brain MRI? Does a young man who has a pituitary adenoma and he's got prolactinoma? You understand, Ron? These are medical decisions. You need to have a history. You need to talk to a doctor, trust a doctor you could trust, because the man is going to tell you things that are very confidential. Maybe he used Propecia, finasteride for his hair. Now his sex drive is bad and he's trying to figure finasteride syndrome out. Maybe he's perplexed. My testosterone is not that low, but when I've used testosterone, doctor, I feel so much better. You understand, Ron? So
Yeah.
History, and then you do a history and physical. You try to find reasons for why he has testosterone that's not optimal. Maybe he's heavy and he's aromatizing. Again, maybe he has a brain depression.
So opioids have play a big role in this too.
Wow. So the next thing is, thank you for bringing it up. So opioids, maybe he's a man. These are real people. This is reality 24/7. Men have they've used chronic pain medicines and now they're on Suboxone. I have many of these men, many. Maybe they're in the program of NA or AA and they're clean now, but they've had such difficult depression that they don't feel well and their testosterone is low legitimately or low normal, and they just feel so tired and they're just having it's called dysthymia, where they're just kind of cruising along in life and their quality of life is just not so well, and they don't want to be Mr. America. They just want to feel better. And so this is my job. I love what I do. And they come in, you have to hear them and listen to them. And maybe they're drinking. Maybe, like you said, maybe they're on prednisone. I had a couple guys that he had low T, low normal. He's late 30s, and it turns out that he was on prednisone for a sinus issue.
Yeah.
Maybe he's on prednisone for a inflammatory rheumatologic condition. Maybe he has COPD or very, very bad asthma, and he has to use prednisone regularly, and it's going to affect his eyes, his bones, and his adrenals, and it's going to affect his endocrine function, and he's going to have low T. So these doctors need to know. I'll be educating doctors soon. That's my next step on testosteronology. So doctors have to understand how to take a history, give the man respect, and then how to cautiously work with the man without breaking any laws or putting someone on steroids, and saying, well, what can we do? Can we give you a trial? Here are the side effects, sir. If you go on testosterone, you start, then you transition over to, for an example, if you do this, this is what may happen. And my first risk is always, if you cross the line at a certain point, you may be on testosterone forever.
Mm.
Like, the guys we know, Ron, right? So
Yeah.
never going to come off this. There you go. So when I tell guys that are more virgins and they've never done testosterone or steroids, but they have testosterone that's maybe 300 or 400, and they even guys that may be actually a little bit low, and they're like, do I treat it? Do I treat it? Doctor, what do I do? I get a lot of those consults. I really enjoy those because I could really help someone think something through before they make a decision, and maybe it's irreversible. So you look at a guy and you say, so if you go on testosterone long enough, you're going to be on it forever. What's the downside? Wait a minute, doc. I don't want to do that. Okay, well then maybe you should, try to lose weight, try to see a psychologist, or maybe this is the best. I tell guys my new thing is, sir, this is the best it's going to be.
Mm.
This is just life.
Mm.
I mean,
In the comments section for your video, someone actually said, I could never imagine having to be on testosterone for the rest of my life.
Ron, do you see that? Now, guys like us, it's like, what are you talking? It's just like second nature, right?
Yeah, what's the problem?
And there's millions of guys like us, because this is where we've been. And now my approach in the world is now to just protect you so you don't suffer a consequence that could hurt you, like heart attack or a stroke or cancer, or maybe the general urinary tract, and just keep the best quality of life there is, man. Rock on with the poodles for 110. So in the end, so that's what you do. But you'll see men. I had a guy, I don't know, a few weeks ago that I explained it to him, and he said, Doc, he got up, shook my hand. He goes, thank you so much. I'm leaving. He goes, I'm not ready to, he wasn't sure. Can you just go on for a while and get a tune up? And that's the anti-aging guys.
Tune up.
The anti-aging guys tell people that they seem to leave these men in their minds that are virgins. They've never been on testosterone or steroids. They're just going to pump them up for a while.
Oh,
and then all of a sudden, 6 months or a year later, these guys are stopping the therapy for whatever reason, and they just crash. It's true.
Oh,
and then they come to me and they're like, Doc, now look at me. What do I do? And I say, you know what, sir? Honestly, I mean, I never start testosterone on a man unless he fully understands that you ain't ever coming off.
Yeah.
Never.
How often do you do, like, we're talking about the other bear, the past steroid users. I assume you always try certain methodologies to try to get their natural production back before introducing getting them on HRT.
This is great. I love this. So most of my guys come to me, they just kind of walk in, and it's just like I can see in the labs that they're on. I can see the brain, the LH and FSH are they're low, they're not measurable. Testosterone may be normal or maybe super physiologic, and estrogen, I can see those red cells are just increased a little bit. Maybe the HDL is down. I could just see it like reading a crystal ball. And they come in, sure enough, and he tells me, so hi, sir, how you doing? Have a seat. And we sit down, and he says, yeah, I started 3 years ago or 5. And then, I say, well, what would you like to do? I mean, when I take care of the pros, they know that I'm not going to give them steroids. The professional, Doc, how do you get around taking care of professional athletes? Very simple. I show them what's going on in their body.
Yeah.
I explain to them and answer their questions to the best of my abilities. And then I say stuff we don't know, maybe, because no one knows. They ask these esoteric questions of, if I do this and that, well, no one's going to know. So then he says, well, and then I'm staying on testosterone and, a gram a week or whatever. I'm going to do this and that. I say, okay, I have to advise you against that right now. Yeah. But if I see an aneurysm, I just saw a guy with an aneurysm. He has an aneurysm. Yeah. So we're going to help save that guy's life. And he's probably 99% of the men that come to me, because they have to pay a little bit of money, it keeps them kind of sober. And then they go, do I want to die, have a heart attack, or suffer? And every single professional bodybuilder in the end is going to more and more come in from time to time to me and they're ravaged, Ron, ravaged. But then they just are. But they understand that that's just what it is. So they're never going to live to be old. Never. It's just they're never going to do never. So and they're going to say, well, I'm not doing that much, doc. Then it's this whole you know dialogue of I would never do that much, and but I'm on 400 or five. I mean, then I just start, okay, well, let's just look at your blood pressure. Let's look at the left ventricle. All my boring stuff. Let's look at, let's look at let's just look at this guy. I mean, Ron, I mean, come on. And then I try to, put them on testosterone. These are guys that have been on for a long time. So no one is ever in their right mind, at least without thinking of they're going to get sued. Stop testosterone. You're gonna kill the man. Could kill himself.
Wow.
Why would you do it? Stop your Lexapro, lady. Stop your antidepressant. Let's make sure you get well and depressed, and then I'll see if I can give it back. It's like these are not.
Said no doctor ever.
So this is why I'm educating doctors now, my next stage of life, because these doctors have to learn, come off your high horse. Let's look at the data. We have studies now. We have medical data. So the truth of the matter is, men, you educate them, and then you see where they want to fall. And then I feel comfortable. I tell them what I feel comfortable doing, what I feel is ethical and medically correct. And then we come to a grounds. We come to a deal. It's a beautiful thing. It's a beautiful thing to do. You come to a deal, and you respect the man, and there's no need to disrespect anyone. I don't say, like the other doctors, bash them and abuse them. Why would you do that? I mean, this man's coming for help. His red cells are high. He's hypertensive. Maybe he's had a heart attack, or he's gonna have a heart attack. Why don't you want to show him the way? I mean, yeah. I just don't understand. And providing medical support for men for protecting their hearts, there's nothing illegal about that ever.
I mean, come on. Yeah, because you still hear in the comment sections, and people just email me, message me, say my doctor's not comfortable with TRT. He doesn't want to. I hear from men who definitely sound like they have a legitimate need for it, and their physicians will not work with them on it.
Go to another physician. Leave the physician. Leave him. It's America. Go somewhere else, or South Africa or Denmark. I mean, I feel sorry for these guys in some of these countries. Mm-hmm. I got a lot of work to do because these doctors are just downright. They're just so unethical. I just can't believe these doctors are behaving this way. Unbelievable.
Are there countries where the attitude toward TRT is even more biased than the USA?
Oh my God! Yes.
Like where?
New Zealand, South Africa, Denmark. The only place that's similar or even better than America, more progressive than America, at least in terms of the reality of steroids being used in androgens, is the UK.
Oh.
Yeah, the UK, London, England, itself, and parts of Europe. I mean, Italy and Germany, I think, in France. I mean, they're pretty progressive, and they have bigger fish to fry. But some of the doctors can be very bombastic and arrogant and abusive in those countries. The UK is probably more advanced than us.
Yeah,
I have guys in the UK are just they're doing they do what I do. A lot of common practice. I have so many guys in the UK that use me as a live. They stream with me, and the doctor comes on board.
Oh,
and yeah. So good job. I mean, England, the UK, you guys are much more progressive. But then there are some countries that are very backward, and they're like Nazis. They take men on androgens, and they want to think they're going to like potentially throw them in jail. I mean, that
actually happens in Sweden, I believe.
Scandinavia I got to really throw a flag at Scandinavia. I got to throw a flag at those guys. Yeah. That they really. But I work with some guys there, and I've turned around some primary care doctors in Scandinavia. So good job, doctors. It's the patients that are putting pressure on them, and these are the men that I'm working with over there are just such nice, decent guys that are in the military, and are suffering PTSD and low T. And he had to come to me all the way. So if this guy's watching right now, he knows he's a super great dude, and he comes all the way to America and then goes back to his country, and his doctor is working with us now, and his doctor is doing everything perfectly.
Wow. I mean,
So this is like what? This is like what one three guys out of Denmark and Norway. I mean, we have a lot of work to do. So, but you know, they need these doctors, in my opinion. That's why I'm opening a whole educational front on these. I'm going to be educating physicians now. It's my next move.
yeah. So my next topic I want to get into briefly is there seem to be a lot of guys who don't have a legitimate need for TRT, but they just never want to come off steroids. We had a question with Dr. T. That's what really wanted. That's why I wanted to do this show, is because it was a guy in his 20s, and he said, "I want to start TRT and this and that." He didn't give much history, so there's still a lot of unanswered questions about this guy. But I see a lot of it. Kids write to me. I call people in their 20s kids. I think, as far as I'm
They
concerned, they
are,
are
they are
kids.
kids. Yeah, those are kids.
And they'll say, I'm on TRT. And I said, what do you mean you're on TRT? They use that. It's a bastardized term now. They use that to describe anything less than a massive amount of steroids. So if
Yeah.
they're normally on 2 or 3 grams of steroids and they take a break of 8 to 12 weeks where they're only on 500 milligrams of test and some GH and some insulin and this and that, that's what they call TRT instead of, we used to say cruising and blasting. A lot of people still use those terms, but I'm hearing more and more kids say, I'm on TRT now. Do you get in your practice? I imagine you do have some younger people coming in. You've
Yeah, no,
talked about it.
these guys come. I don't know. The young guys. The problem with youth is that it's wasted. The health and all this is all those idioms, right? That they don't. They just don't feel it. They don't. They feel great. They're freight trains because you're so young. You could do absolutely anything, and then as you get older, obviously you start feeling the bruises. But people, they do come into me, and they do. You're right, though. They do come in. So what's your? I'm on TRT. Okay, well, how much are you on? Yeah, 600. It's like, okay, it's not.
Yeah.
Yeah, and I've even heard like TRT of a gram or 800. I think they kind of look at me kind of like, can you agree with that, Doc? And I'm like, I don't agree with that.
They
So,
want your blessing.
but I don't make fun of. I'm still kind to them. I'm still kind to them. But in the end, they do that, and then again, it's the same thing. If they ever want to come off, which they really don't, because everyone's blasting and cruising, as you said, because they just don't feel good. And we're trying to do the studies now to see if PCT is going to work. But in the end, there are men that say, Doc, let me just ask you something. I don't want to come off. So I don't need to be recovered and any of this kind of stuff. You're really upsetting me with that. I've had guys criticize me and I take it. I take the criticism,
Yeah.
so I don't need to be recovered. I actually enjoy steroids. I want to be on. I want you to protect my health. And
Mm.
I say, oh, okay. Okay, well, then I get into a It's not a cat and mouse game. I get into a dialogue of, well, the doses you're on. Let's talk about. Come on, you're a smart guy, buddy. You're a bro science guy. Let's go right into the dialogue of the hypothalamus and the pituitary. You want to get good? Let's get into the artery. Let's talk about the endothelial function and the plaque progression. And yeah, 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 yeah. I mean, it's like, if you care, if you want to live a quality of life, it's not sustainable. I end up explaining. So in the end, I'm telling you, I get the most ardent guy that's on steroids that loves it. I get him down to more normal levels. Sometimes he has to do it himself because I just don't feel comfortable prescribing those big. I won't do it. I don't want to lose my license.
Right.
So I know what I can do and I know what I can't do. It's very there's I'm protected with data now. There's a lot of anabolic steroid-induced hypogonadism. I mean, my colleague Bashane is working with patients. My colleague at Baylor, Dr. Lipschultz, I will refer people to them right now. Go. Lipschultz is there. Go use them.
Hmm.
We all have a waiting list of about a month or two. I mean, I had a guy from Texas that actually Lipschultz he just never called him back. So he goes, Doc, I'm in Texas, so I was going to use Lipschultz. So I'm going to use you. So he's going to come see me in Florida. I'm not scared of competition. I love these doctors. I told you, Lipschultz, I think, is kind of a cowboy down there using too much HC. He's using 3,000 IUs of recovery of HCG, and there's no data for any of this. He has some data himself, but it's like me, because I wrote a book. Is that I'm the god of the world? That's ridiculous. I've been working well before Lip, Schultz, or Bashane on any of this stuff clinically. The truth of the matter is, we all have to help these men, and don't turn them away. Help these men. If a guy does one cycle or one, week of Anadrol or a SARM, does he need to be recovered? No, that's ridiculous. But other guys love a lot of men are going to love steroids.
Yeah.
So I work around that with them. I don't give them steroids. I don't give it. I show them, look at your blood pressure, look at your heart. You have family history of heart disease. Your dad had a bypass in his 50s. I mean, just, are you concerned for that? Maybe you're 25 now, 26. I mean, you're not going to have a heart attack, God forbid, sir. But when you're in your 40s or 50s, if you have it happens to men that are not on steroids. You could accelerate that. Do you want to come off everything and look like you have AIDS? Like some of these, I know you're laughing. I mean, these guys look like they have AIDS.
Yeah.
I mean, they look horrible. So there's really, really something going wrong. If you use too much androgen, you're going to pay the piper. And
here's a question, though, because the kid that wrote to Dr. Tuliados, he was in his 20s, and he said, I got off a cycle and my T is low. I'm thinking, well, yeah, you're 20 something. I would think, and this might be a sweeping generalization, but I started in my late 20s. I started at 27, and in between, I would take time off, and I don't know, I wasn't doing blood work, but I could tell how I felt and how I looked. But I would go by my energy levels, whether I was depressed or not, sex drive. That would let me know when my test levels were back to normal. And in my late 20s, early 30s, I used to bounce back. I'd say within 6 to 8 weeks, I felt fine again. And then, a couple weeks later, it was time to get back on the steroids.
Wow, incredible.
But I'm saying, how many of these guys in your 20s? I would think it would be very difficult to do enough damage where you gave yourself anabolic steroid induced hypogonadism at that premature of an age.
No, Ron, there are men. This is why we're studying the spectrum of it. It's a spectrum, right? Yeah. So it's like you're like the average pretty resilient bear that you're in the 20s, you're young, you're a freight train, you're training hard, you can do some steroids, you feel obviously, you get the gain, then you come off with or without PCT. And then
no PCT, never did it.
Yeah. No, I mean, this is the 80s and stuff in the 90s. I remember where guys weren't doing it back. They just came off. I mean, they didn't really have it back in the 80s at all. Maybe the 90s it came into play. And now we know that Clomid is poison. And if like you're using so much HCG, the Clomid is just useless. We're trying to, I have doctors I'm working with, as you know, that we're trying to like figure out all this stuff. And we're in our data gathering mode right now. So we're just have to sit back and wait, because we're getting incredible data pouring in every day. It's unbelievable. I talk to this guy a couple times a day on our, what's going on. So it is just amazing. So most guys like you, the average bear, you cycle on and off. And then there's that one cycle. I talked to a guy from the UK this morning. Doc, I did my one last cycle. I haven't bounced back. It's been 7 months.
Yeah.
He goes, I am going to go on forever, man, aren't I? Wow. Yeah. And he's a real estate investor over there. He's just some bloke, he's just some guy. He doesn't, he did it with his blokes, just to pump up a little. And he has a family and 2 kids, and the wife's in the background. I have a great time. And his T is like, it's like, I don't know, what was it, on his scale, low normal. But he's like, my sex drive, Doc, no more morning erections. I'm exhausted. Well, you better go see a doctor and make sure there's nothing else wrong. And then beyond that, he goes, man, I just did that one. It's the straw in the back, right, Doc? So there you go. And he's done like 8 cycles. He was very kind of arrogant, like, I do it for 2 months, 3 months, come off. No, he goes, I know I'm going to go through a period. And then 7 months later, he's dust to the wind. He's never going to come. I mean, I said, sir, this is your new normal. This is what you have. And he's only he's like 32, 34. I mean, he's not old.
Yeah.
And he's like, Doc, oh my God, I'm old. I'm 30. It's what I'm like, sir, I'm 55. I'm a freight train. I'm still trucking along like a monster. But it's like, so what are you talking about? Well, you've done, how come, Doc, I've done all those cycles and it never affected me? Well, it's the camel. You keep loading. So what am I going to tell you, sir? No one knows. So see, I don't know if I answered. We're just having our dialogue today, but
Probably.
we're just kind of
Well,
bantering. But
well, that led me to my next question that I had was, what can the time frame range where it's, if you're going to get it back, if you're going to get your normal production back, what's the longest you've ever seen someone take to regain their normal levels?
Oh, that's a great question. That's one of the things we're looking for in our studies, in the end for like, but there's so many variables, who you are, how old you are, medical conditions, depression. Do you have depression? Was it one cycle, two? Was it this? Was it D-ball? Was it SARMs? Was it, oh my God. So in the end, how long? Within 90 days, I'm going to give you some real numbers. Within 90 days, you should be back.
Really?
Because the drugs are out of the system now for about a month or so, and then you have another month or so where your brain is exposed, to itself, to whatever your testicles are producing and whatever else is going on. We don't understand. And the brain, and some men I have guys I've seen in their 40s that have done countless cycles, 100 cycles, and they bounce back to 700.
Hmm.
It's unusual. I've seen them. I've seen them. These are just robots. The average man is never going to tolerate the average guy. We're trying to find out what the average guy is. We don't know yet. So, that's always it's a moving target, right? So, the average guy's changing because the SARMs are on board now. Ron, a lot of young guys, they don't want to be these big mass monsters. You know that, right? You know that.
Yeah, they just want abs now.
They want to be just ripped and metrosexual, and they just want to be. I mean, it's really amazing. So the guys in muscle and fitness, the guys in muscular development are different. The heavier old school crew, the muscle and fitness men's health guys, which I'm doing stuff with. I work I'm like a media whore. I'll kind of work anywhere. They're just different. They don't want that estrogenic, puffy. They want to be lean and ripped, and that's why they're all doing SARMs and in oral, Anavar, Winstrol, maybe some Tren because Tren, no one's getting really fat on Tren. So I see it all, Ron. So it's changing, but the brain gets affected differently. And then at what point, when you feel so good on testosterone and steroids, you guys get to a point and they go, who doesn't want to just feel like this all the time? So cross this line, cross. At a certain point, Ron, they're just going to live on testosterone. That's why I'm busy, because millions upon millions upon millions of men in the world are living on testosterone. The bad part of it is they're just doing it from the streets. They have no medical support.
True. So I'm going to rephrase that last question in a very simple way for our viewers. Good luck with this one. If you've been on steroids and you go off and your testosterone has not returned to normal levels within blank months, so blank is the number I'm looking for, it's probably never coming back.
Up to 1 year.
Okay. So give yourself about a year max.
Up to you. But then we preface that with saying, like, how you can't think a week later that, hey, I'm not back yet in 2 weeks or a month. Come on.
Yeah.
So around 90 days, around 3 to 4 months, it should be you should be kind of feeling some tickles and feeling pretty good. And then it's like, can you really fully be back 7 months, 9, maybe 12 months? What you're looking at about a year after, which I see this all the time. Doc, I've been off for 1 year. What is going on? Look at that number. I feel like shit. Sir, I'm going to diagnose you slam dunk right now. Anabolic steroid-induced hypogonad. This is common as the day is long. So that's why I'm telling guys, if this is concerning to you, go get a mountain bike. Wait, they do steroids too. Go get a poodle. Go get a golf. Wait, they do. Everyone's doing steroids. I mean, just go read a book. I mean, go do something. Don't enter. Ron, do you agree with me? If
I'm
you're
not
a
really sure. You can finish your sentence because I don't even know what you're talking
don't
about at this point.
do it. Don't do steroid.
Oh, okay.
If you don't want to enter the world of staying on androgens forever, never take one pill.
Yeah. I tell guys all the time, you're not going to, they say, well, I'm just going to do one cycle. I said, I've known
Yeah.
hundreds, thousands of guys who said that. None of them did one cycle. Nobody does one cycle.
It's
That's
too
like that's like saying, I'm going to do crack one time. You're not going to do
it,
crack.
it
You're not going to do
so
heroin one time. You're not going to do crack one time.
it's that, and that's what we're looking at the study too. It's so addictive, and it's a slippery slope. It's just it's subtly addictive. You know, in the end of the day, when your brain doesn't produce any more testosterone signals to your testes, then it's physiologically. What point is that line crossed? There's so many variables, and a lot of guys just live. I just talked to a guy from South Africa where his test is low normal. He's off since April, and he's 40 something. These are executives, and he had some side effects he just didn't care for. And his wife, so he's so doc. I think what you said in one of your videos is this may be the best it gets for me, and I'm okay with that. And if I decide to go back on, I'll just go back on carefully. And you see, the problem with these guys, they don't have doctors like me in their in their neighborhood there,
I mean, who does? Come on.
It's true, it's true, it's true.
Let's be real.
But I mean, but it's like, these are not steroid users, Ron. So the guy said to me, I didn't do steroids. I just did TRT, which is real TRT, like, half a mil of cypionate every, twice a week. I mean, this is like, that's not a steroid dose, Ron, right?
Nah,
I mean,
bupkis, yeah.
that's a, I mean, so I'm just, it's so exciting to be a testosteronologist and to be the first of the world and to be so looking at this huge,
I should have asked you this much earlier in the discussion, but they look at total test numbers. How does free testosterone factor into that, or does it when you're evaluating someone?
Watch my video on how sex hormone binding globin affects testosterone levels. That's answered there.
Okay.
So basically, testosterone is carried on albumin and sex hormone binding globin, loosely and tightly, respectively, and it's circulated through your body because testosterone is oily, and your body is your blood is mainly the medium is aqueous saline. So oil and water they're not going to mix well. So your body carries it to distribute it on a carrier where it's useless. It's totally inactive. And when you're measuring total testosterone, you're measuring really an inactive portion of what's being carried in your blood, which for most cases is going to be proportional to the free. Free testosterone is a teeny. It's actually 1,000 times smaller in units. It's a nanogram to a picogram. This is all science, guys.
Yeah.
So when you measure the free, that's why I tell guys, please, if you really want to measure this number, don't get a total testosterone. Doctors, wake up. Please, you're wrong. If you don't know something, doctor, refer to a testosteronologist. I'm starting to train the world. Total and free are going to be related to the sex hormone binding globin, not to mention albumin, but that's going to give you an assessment of the biologic androgen that will get into the brain.
Yeah.
Voila. So so free testosterone is a fraction, but that's the one that really has the effect. And when men are on steroids, the sex hormone binding globin is driven down. Then when they come off, not to mention 20 years later, I have data on this, it's up and it's so high up, and it's still it's too high, way over the upper limit normal, and then therefore it's rendering their testosterone ineffective. And this is anabolic steroid induced hypogonadism.
What are the values? We know basically under 300 is low total. What's low? What's a low value for a free testosterone?
I can't see. So there's three different scales in the world. It depends if they're doing the nanogram per deciliter, if they're for deciliter, picograms per milliliter, or there's a millimole. So the ranges are teeny. It depends on what reference range, Ron, we're using. So because I'm not going to just use our American rate. They're all metric, but I'm not using the American. So I looked at the guy in the UK today. He's not using the one America uses, and I'm looking at the guy in South Africa and the Netherlands because they're using the labs that are in there because South Africa is the Dutch, right?
Yeah.
So I'm looking at lab values that are we don't see in America. So I have to train my brain, and I have to sometimes do kind of my unit calculation, or it's the reference ranges are right there, but the reference ranges on to us can be as far as looking at the numbers 50 to 150. This is a picogram per milliliter. So not the deciliter, not that there's a picogram. It's 1 divided by 10 to the 12 versus nanogram, which is that's the one that's per deciliter, and that's the total. So I mean, I don't know. I'm just telling you that this is scientific stuff.
So in the U.S., if I'm looking at my labs, 50 to 150 would be a normal range of free testosterone.
Yep. Sometimes it can go up to 225. It depends. There are ranges that go to 7 to 50. Again, I still can't even get my head around. I should ask a PhD lab biologic tech guy, why do we have all these different ranges? I mean, it's really true. It's really true. So that's why I think everyone does. I kind of answered my own question. That's why everyone just likes to use the total, because it's all the same, where it's the 250 to 1100. The free ones are all going to be depending on what they're really looking at and who decides what that range really is. And they theoretically should all be equivalent, but it's a little apple to an orange, because they're doing different. They're using different technology, and they're using different units. So so what guys should do when they use a lab, and it's a good lab, it should be liquid chromatography. It should be a good lab, and I'm not going to say lab names because I'm not here to sell lab names.
Quest.
But it should be Quest or LabCorp. I mean, a big carrier that has a lot of staff. They're going to use the standards. They're going to be on the cutting edge. They're the guys that have the standards. They work with insurance companies, and they can't just plug something into a soda machine and think this is what you're going to. There's your number. So these are PhD. These are pathology people, and these are lab people. This is biological. These are career people. This is a career. So they have references. They're going to have a reference range. Look at the reference range. It should fall within the range. If you're down to the bottom of the range, you could break it down into quartiles. That's very smart to do, looking at the quartiles. If you look at a Gaussian curve, you break it down into lower 25%, up to 50, 75, and 100%, right? Gaussian curve, that's how it should be looked at.
Yeah, you lost me there, but hopefully some of these viewers took, is that from calculus? What's that from, Gaussian curve? I don't even know.
Statistics? I don't know.
Yeah, with some class I never took. But, okay, well, Doctor, I think you've given us a good overview as far as what to look for in terms of if you are a candidate for testosterone replacement therapy. HRT, TRT seems like it's used interchangeably, but
HRT is women. My understanding is TRT is men, but
okay, I'm glad you said that, because I've been saying TRT, but I didn't know if it was the right.
HRT is like Suzanne Summers, and like women.
Three's Company was a hell of a show.
Remember that? Okay.
So yeah, and again, if your doctor will not cooperate, if you mention TRT and he does this to you, find another doctor, man. Find another doctor.
They're out there. I'm going to be training them soon online. The whole world.
Would you recommend, if a general practitioner is skittish about TRT, would you recommend they try to get a referral to a urologist or some other specialist?
So here's the deal. I got to be careful. I don't want to put my brotherhood down. This is so detailed now. It's not endocrinology per se, because it involves the cardiac system, the hematological system, the psychiatric system. So it's a medical specialty. So endocrinology guys are going to be my number one go-to. But urologists are surgeons of the general urinary tract. These are surgeons. They're not medical experts. They're surgical experts. They have to know some medicine. We, on the other hand, have to know no surgery. So these guys are under pressure. They're surgeons. They work in the operating room. So how can you think a guy that's going to work in the operating room all day long is going to understand a medical subspecialty of testosteronology? It doesn't make sense to me. How does he understand the red blood cells, the polycythemia, the endothelial aspects? How? How? It's not possible. So that's why I'm training testosteronologists, which will be internal medicine experts, and then they're going to be trained to be subspecialists and taking care of men on androgens.
So eventually, will there be a specialist called a
Yes.
testosteronologist? Okay.
Yes. I have it right now. It's
Well, I
all
know. I'm just saying, like,
we're
you could be
the
anywhere in
future
the country and you could look up a local
world. World.
testosteronologist.
It's going to be the world. This is going to be a world takeover. We're training doctors in the world to be testosteronologists, and we're going to have even beyond that, we're going to have other aspects. But it's all coming out now. So because it's just too big to not do, it's too big to do. But you have to be an internist.
Okay.
You can't just be, you're not the anti-aging clown. I mean, that's just a clown.
Oh
I mean,
man.
that's just in New York. I mean, I'm from New York, so this kind of stuff just comes out. You have to have a good time in life, and any guy anti-aging, it's like a buffoon. What I do, Ron? I do this. The monkey comes down. It gives you a little chip. It gives you a little the monkey. These are a bunch of clowns.
Well,
These are a bunch of.
I thought the monkeys would give you peanuts. Isn't that what they used to give you? The guy with the organ grinder and the monkey would, no? I thought it was. Anyway. Well, Doc, you've been more than generous with your time. Thank you so much. I know you got patients all day long. You got patients in the office, patients on the Skype from Dubai and South Africa and everywhere else.
It's a good time. It's a good time.
So,
I do thank Ryan. Thank you. Because
if you guys want much more organized videos that are outlined in timestamps and everything, and they follow a logical pattern, please go to Anabolic Doc channel on YouTube. Dr. O'Connor does a splendid job with those. We tend to just meander and have fun discussions.
That's what we do.
That's our thing. It's cool. I enjoy our time together. So I want to remind you guys, check out the book, America on Steroids, A Time to Heal. If you want to get in touch with the doc, he has two websites you can contact him at, metabolicdoc.com and anabolicdoc.com, because that's a question we always get. How do I get in touch with him?
Ron,
we go to his website.
Ron, now we have testosteronology.com.
Oh, really? Well, that's going to be too hard to spell. Let's stick with metabolicdoc.com. I couldn't even spell that if you put me on the spot. Testosteronology. We'll do a video about testosteronology eventually.
Ron, testosterone, drop the E and add ology.
Testosteronology. Got it. Okay, that wasn't so bad.
I got it.
A lot of people can't even spell testosterone though.
It's tough. It's a tough.
Oh man. Okay. So again, guys, check out his websites. Check out his YouTube channel, anabolicdoc.com. Pick up the book on one of those websites or Amazon.com. Thank you, Dr. O'Connor, for sharing your time, your expertise, your knowledge. You're the only testosteronologist I know, and I'm glad I know that one.
So, I do appreciate it, Ron. Thank you.
Guys, we appreciate you watching the videos. Please keep watching. If you have suggestions for future videos, just like you do with the doctor's videos, leave them in the comments, and I'll certainly consider all options. Thanks for watching, guys. Ask the Anabolic Doc. We'll see you next time.